12:10, so we'll get back on schedule. It's my pleasure to introduce our next presenter, Captain Seth Lockard. He's going to speak to us on community paramedicine serving older adults.
Okay, so I think everybody should see my presentation now, correct?
That's correct, yes, sir.
Alrighty, so thank you. I want to make sure I had it set up right. You know, it's the year 2023 and I still struggle with technology and Zoom, so I wanted to make sure that I'm showing it all right. Hey, I want to just introduce myself. My name is Seth Lockard. I have the great pleasure of working for the Lexington Fire Department. Lexington is a unique position because we are the ambulance agency in Lexington. So when somebody calls 911, ambulance in the Lexington Fire Department is the unit that's responding. So it provided us a great bit of information, and we started this program. Next month will be 6 years ago. Next month will be 6 years, and we started this program in September of 2017 after we received an assistance to firefighter grant. That grant was an amount of $252,000. And the intent of the grant was to get the program off the ground. It provided the seed funding to start the program. When we did it, we were looking at a focus on our high utilizers. We are a great collector of information and data, but we had never really studied the data. And in 2017, when we started the program, we started driving down. We started looking at what our high utilizers were, and we had never taken the time to investigate who our callers were, why they were calling, and now we're looking at it. It's evolved continuously. And the reason why we did this is because in 2013, you'll see some numbers up on the screen. In 2013, our ambulances made 33,500 ambulance runs. And by the end of 2017, when we were starting our program, that number had grown to 48,238 ambulance runs. It was a 44% increase in that time period. We were looking at a run volume increase of 8 to 10% every year. And so a barrier for us is that at about 8% of 50,000 runs is 4,000. So we were going to be looking at almost needing an ambulance every year to year and a half to be added to Lexington. And that's an economic impossibility. To staff an ambulance, it takes 12 personnel. It takes a new vehicle. It takes all the equipment to go in a vehicle. But the personnel cost, budgetary is about $1 million a year, including benefits, pension, and all those things. So to be looking at adding $1 million to a budget every single year and a half is a significant hurdle to overcome. And so we started this program, and when we started drilling down onto the numbers, we realized, and interesting, in 2017, at the end of the year, we looked at our high utilizers. We identified that as anybody that had called 911 for an ambulance more than 10 times. And we actually looked even further. When you look down to the top 226 people, they accounted for 9.3% of our ambulance runs. So this is 0.07% of Lexington population was accounting for over 9% of our ambulance run volume. So that became our target population. Individuals that were calling for fairly lower acuity situations, sore throats. We joke about the stub toes, but stub toes, people that were calling to get their medications refilled. They had gotten a prescription at the emergency room. Well, I go back to the emergency room to get my refill done. A lot of the hospitals were doing the meds to beds program, whatever you want to call it, where the pharmacy was providing medication at discharge. They were going back to the emergency room to get that prescription refilled. So we started engaging these individuals. And one of the things that we learned early on is that we didn't want to become the resource itself. We wanted to be a connector to the resource. And so we spent a few months figuring out who in the community that we needed to engage with, what programs, what services. When we talk about prescription delivery, what pharmacies delivered, and go back in 2017 and 2018, not nearly delivered as they do today. And so we started tackling this problem. And at the end of 2018, we saw about a 2.3% run volume decrease. Not a significant drop in run volume, but when you take into consideration that we didn't see an increase of 8 to 10%, a significant run volume reduction overall. And so that's what we started off. We went live in February of 2018, and 2018 was a pretty busy year for us. We did a couple of things. I see a typo now. We did a couple of things. In 2018, we applied for a federal grant, and we were awarded that in the end of 2018. And we also partnered with the UK College of Social Work in 2018. As I said, we were looking at how to sustain this. I told you we got that seed money. That seed money was only supposed to last a year. Ended up lasting us 18 months. And we were trying to talk about sustainability. How do we get this program supported by the city to keep going, because we were making such a positive impact. And so we had met a faculty member at the University of Kentucky. It's not OK College of Social Work. It's supposed to be UK College of Social Work. Her name was Allison Gibson, and Dr. Gibson sat down with us, and we were telling her all the things that me and Patrick Brandon, my coworker at the time, were doing. And it was just the two of us. We were talking about all this stuff that we were doing, and she looked at us and said, "You're doing a lot of social work." And we're like, we're the most undereducated, untrained social workers. But I think one of the things that we were willing to do, I think two things going for us is, number one, we were wearing a fire department uniform, and that opened up a lot of doors. And two, we weren't afraid to ask stupid questions because we didn't know. And so we asked lots of people, lots of questions, a lot of agencies questions. How do we engage? How do we go about this? And so we were willing to do that. And so she said, you all need to become a practicum site for the College of Social Work. And in that school year, 2018, 2019, we actually became a practicum site for 2 master's level students. That summer of 2018, we also realized through experience of calling our friends that we knew in the police department, we were tackling our high utilizers of fire and not EMS. The police also had an issue with their high utilizers. And so we pitched to Chief Weathers, why don't you give us a detective? Why don't you give us a police officer? That way we can work together. A lot of what this program works and serves is some component of mental illness. And in Kentucky, the laws around mental illness are really written towards law enforcement, not so much EMS and paramedics, but police officers. In Lexington, over 95% of the officers have undergone the crisis intervention training, which is 40 hours of mental health training. Paramedics don't get that. And so we were trying to utilize the tools in Lexington. And so we got a police officer assigned to our team. So it was me, Patrick, and a detective from the police department, and we were going out and seeing people. The COAP grant was a comprehensive opioid abuse program. We received a grant to hire a social worker, and we ended up one of our social work students, Maria Sloan, was hired as our first civilian employee as a social worker. And as I said, it was an opioid response. One of her primary tasks was to follow up on overdoses that are occurring in Lexington. 2020, February happened of 2020, and we were actually going days of not having overdoses, allowed us to see more people through our high utilizers. But as a supervisor, I was getting worried that Maria was going to be out of a job because she was grant funded, and COVID happened, and we saw a significant increase in our overdose response. And we also got hospital support. Mayor Gordon had driven the conversation with the hospital administrators, and the hospitals were willing to help fund the program for a year. So the 3 hospitals in Lexington, UK, UK, St. Joe Hospital, and Baptist Health all contributed funding to help keep the program going. And we continued to look at our high utilizers. But that hospital support was great because it required some MOUs to be assigned, which helped facilitate the whole conversation back and forth of communication about patients. We started receiving referrals from their emergency rooms, their floors, their case management teams, asking us to follow up on individuals that may not have been a high utilizer because they necessarily weren't going by ambulance to a hospital. They may have had a loved one or a friend. We even had people going by taxi. They still were going to the emergency room. And so we got to be able to provide that key component. Opioids are still a major component of us, and CORE, Kentucky Opioid Response Effort, has been helping support a person. I jumped. COSAP also brought us a second social worker. Her name is Mackenzie Gross. And so we were able to keep both Maria on payroll and hire a second one, Mackenzie Gross, which is phenomenal. CORE has helped fund us as well. They've actually provided us an additional firefighter paramedic for the last few years, which is a great partnership. And then one of the neatest partnerships that we've had, one of the in a way challenging, is we've partnered with Anthem. Anthem is in the Medicaid space. We have worked with Anthem for about a year now, working with their Medicaid subscribers and navigating them to the resources. I think one of the things that's missed is they are a great resource for their subscriber, but there's also a lot of great resources in the community that can help navigate and provide services that even the insurance companies don't know about. And so we keep working on our, it's kind of evolved. We do a lot of mental health, our high utilizers and substance use situations. Let me back up. How do we get our referrals? I don't think we anticipated the opportunities internally for our referrals. As I said, we do a lot of data analysis. Our patient care reports that our ambulances make are done on an electronic patient care report. Program is really cool that we can go back and query based on complaints, based on treatments that were done, injuries that were there, or even looking at an address or a specific name and date of birth. So it's really a cool, powerful tool. But I think the piece that we weren't expecting was getting early on. It was text messages from crews. Hey, we've made Miss Smith 5 times this week. Can you check on her? And Miss Smith didn't show up on our radar because Miss Smith was 5 times in a 1-week-ish window. Why did she fall all of a sudden 5 times in 1 week? But the other 6 months, she hadn't fallen once. What's going on with Miss Smith? So we generated a computer referral page internally. So now our crews can go in and submit a story that gets emailed to the whole team. The reporter can provide us information, can tell a story, give us a reference number to an incident or a series of incidences, maybe provide telephone numbers for family members, a lot of good resources for us. And we didn't anticipate how valuable of a tool that was going to be. And I'll tell you a story. I was on an ambulance one night and had made a run to a lady that had fallen, and I thought she had broken her hip. I would have bet my life savings she had broken her hip. She could not walk. She could not bear weight. She was a retired attorney, so she knew her rights that she could refuse treatment. She understood the risks associated with it. She had the capacity, could articulate not going to the hospital and what the potential consequences were, and was adamant about not going to the hospital. And I had no recourse. I could not force the issue. And at this time, we didn't have a program like this. And so I worried about it. It was a Thursday night, worried about it all weekend long. Come to find out, the Monday was a holiday. And one of the guys on the run with us that day also worked in an ER and texted me about 3 in the afternoon on the holiday and said, guess who just came through the ER? And she had a broken femur. And so we have now realized that having an outlet for these situations, because our crews don't have as many opportunities. Our crews are still very busy, but they can't force individuals to go to the hospital that have capacity, that can articulate not going to the hospital, can articulate what the consequences associated not going to the hospital. So now they have an outlet to go back and say, hey, can you go check on this individual, make sure that they're safe, make sure they have resources. Maybe their housing situation was less than desirable. Maybe their floors are holes in the floors, holes in the ceiling, holes in the roofs. What can we do and now navigate them to resources? So it's a great tool to take off that worry from the crews, to give them the ability to rejuvenate themselves and not burden and bury that burden with them. And we do the same thing with the Lexington Police. We have a great partnership now that we have an officer assigned to the team. We work closely together. There are things that when you're out on a run that may make a crew go, something doesn't feel right. I don't know what it is. And so now we have a group that will fall back on that. And one of the things that we do is we follow up within a few days to make sure things are going well. We also get external. As I said, we have a great partnership now with the hospitals. Up to that point, HIPAA was a big barrier. EMS providers are looked at differently than doctors and hospitals. And there are some caveats in HIPAA that you are allowed to provide continuity. And so if I'm going back out to provide services to an individual, we can get information back, especially if it's a patient that Lexington transported to your hospital and I'm going back to check on this person. There is some information that can be shared. And so, but having that agreement, we now work closely with the case management teams. Still a barrier because the hospital systems are generally big. And so this person over in this unit knows about us, but the case manager in that unit may not know about us. So it's still a battle that we have when we're working with, navigating individuals and advocating for individuals. Almost every single city agency in Lexington now knows about us. We have a great working relationship with our code enforcement team. They work with us. If we have an individual whose house is, maybe falling into disrepair, the city has some grant programs to help bring up some of those housing situations in a little bit better condition. And so we've got a great working relationship. Two, they are out in the public and may encounter somebody that we may need to go look at, we may need to go engage with. And so having that opportunity is a good thing. So we do that. So we have that great working relationship. Other social services programs in the city and in the community. We've gotten referral from home health agencies that are serving the elderly population. So this is a next slide is a picture of what we do. The picture on the left was our detective. And she was sitting downtown and underneath the pavilion at Tandy Park, the Fifth Third Pavilion there. And the young lady that lives there is an elderly lady that had found herself homeless, experiencing homelessness. And we engaged her. That day, we ended up all spending time with this young lady. She had a really good working relationship with Detective Smith. And so we were all kind of filling in some time space, waiting for Detective Smith to be able to come down. We were able, within a couple of weeks, we were able to get this young lady into some long-term housing, independent housing, and is doing well. The picture on the right is Mackenzie Gross working with an individual. When we show up, we have electronic equipment, computers that we can, if an individual doesn't have insurance, if they're eligible for SNAP benefits, we'll start working on getting them signed up for SNAP benefits. Whatever resource that they could possibly benefit from, we'll start working for. And one of the things that we still work on is, which doesn't see this, is in these pictures, is a lot of the elderly that are sustaining falls. One of the great things about it is One of the services that the fire department provides is a lift assist. It's become probably our highest utilized. As you look at the population in Lexington, the population of people that are elderly, it continues, percentage-wise, continues to grow. And not everybody has the resources at home that can get up off the floor. They may not have a loved one that can help them. There's so many people that are living independently at home. And so oftentimes we're calling. So if you look at these numbers in 2018, we made just under 2,200 lift assists. And last year we made over 3,300. That's a 50% increase in a few years' time. Our EMS numbers continue to go higher as well. And one of the interesting things that we try to do is to go in and educate the clients and the individuals about ways to reduce that risk, right? Grab bars in the home, removing rugs from the house, anything we can do to educate, to make sure these individuals are not falling, to reduce that risk. I say everybody, that's an exaggeration, right? But there's always that chance of falling once. And that's detrimental, potentially a detrimental thing. But if they're a recurring falling, what's the issue? What's the problem? And sometimes it's a matter of engaging their primary care because, hey, maybe their blood pressure medicine's a little too strong. And when they stand up, they're getting dizzy. Maybe they're dehydrated. Whatever the situation, we can help navigate and try to reduce that risk. But asking the questions as to what's going on, what's changed now, as opposed to the last 6 months when you didn't fall. Are you weaker now? Why are you weaker now? Well, when's the last time you saw your doctor? And then becoming a voice to those individuals and advocating for them, whether that's through maybe they've fallen and are transported to the hospital. Maybe it's advocating at the hospital to make sure that everything is looked at, not just an x-ray to make sure they don't have a broken hip, but make sure that the blood work is looked at to make sure that those electrolytes are in balance, and make sure the patient's not orthostatic, so they stand them up in the hospital, make sure they're not getting dizzy because maybe they're dehydrated. Just helping them be advocated for in the hospital. So that's kind of what we do. When you look at moving forward, we are working on continuing to educate our first responders about roles that they could be active in responding to falls. One of the things that we advocate for with our crews is to look at their smoke detectors when they're in somebody's home, so that make sure that if the fire were to happen, because the department itself has a smoke detector program, and we can come out and install. Our next go-to is to develop and provide educational brochures. We as a government agency want to make sure that we're providing the best information. So we're looking at brochures now to make sure that we're getting good, reliable information in the hands of individuals and get them printed. And then we have a social media platform. A lot of individuals are, a lot of elderly individuals are still engaged in social media. That's how they keep track of their families, Facebook pictures and stuff. And believe it or not, Lexington Fire Department is a highly followed social media presence in Lexington. And so we need to utilize that tool to be able to advocate for and educate individuals in the public about making sure that their fall reduction are reduced, and making sure that when they're, have grab bars in the appropriate places, making sure that they remove those rugs, making sure that their light bulbs are changed so they don't have dark areas in the homes, so they're not producing a trip hazard. So those are some of the roles and things that we do within the fire department, within the community paramedicine program. I see some questions, so bear with me. Let me go with does anybody have any questions they'd like to ask? So yes. So Smart 911, somebody brings up Smart 911. We do. We use Smart 911, and if you all don't have Smart 911 in your community, advocate for it. Smart 911 is a great tool for individuals to be able to put canned information in. So You know, if somebody is falling a lot, one of the things that they can do is put key information or maybe keypad information or contact for loved ones. So when they are to call, if they call 911 from a telephone number, that information is reported to the dispatchers. We have installed the master lockbox things for the keys to be installed. We've put a number of those. It's not something that we have the resources to do. We have the manpower to do. We've been lucky enough that a number of people have been able to reimburse us for those. But now we have a little bit of a cash fund that we can buy a few of those and be able to provide those. One of the things we want to reduce in a fall situation or lift assist situation is if somebody were to call from the home and say, I've fallen and I can't get up, they're home alone, nobody can get to the door. What is the best mechanism for us to get into the door, into a door? So we want to make sure that we have some mechanism other than a pry bar to a door. And so we really advocate and will put keys in master lock boxes. That information gets into our dispatch information. So when our crews are dispatched, they know where a lockbox is to get to a key. A lot of the apartment complexes do it. A lot of the older, over 55 apartment complex have put in, lock boxes, or what we have is called the Knox box, which has a key that every single company in our department has. And that key, inside apartment buildings, they can put master keys in. The boxes are a little pricier than a master combination box that you can get at a Home Depot. But it's all information that we can put in our CAD system or in this smart 911 system. As you all are a social service group of individuals, the smart 911 system is a great program for not just individuals that are elderly, but individuals that may be on the spectrum, that may have elopement issues. You can upload pictures, you can upload other details, pertinent information about the individual. So it's really a great tool to have for any type of client that you're serving. So when they call 911, that information is uploaded to the dispatcher. So it's a great tool to utilize. So any other questions anybody would like to have? We're not unique. I don't know where you all are from Commonwealth of Kentucky. There are currently 10 programs operating in the state of Kentucky. The 10 programs, everybody has a little different focus, all kind of depending on what their need in the community was. As I said, we started off looking at our high utilizers. We've evolved to being a kind of a catch-all problem solver within 911 services in Lexington. So we are doing a little bit of everything. And so find out in your community. Those 10 programs right now are operating under a pilot program. The regulations are being written, currently being written, it will be not limited to those 10, that any EMS agency in the Commonwealth will be able to start a program like this, kind of just figuring out what your needs in the community are. We've been fortunate enough to be actually to do a little bit of traveling. Chattanooga, Tennessee hosted Patrick Branham down for a long week, and he explained to them how to get a program running. A lot of programs, a lot of people view manpower being a barrier, but you got to look at the community partners in your community. As I said, we went to the College of Social Work, and I think it's a great program. I think it's a great program on both fronts. We get to give these students opportunities to see individuals in their environment, as opposed to working in a doctor's office or some type of office setting. We're going into people's homes and being able to afford that to social work students and see that environment that an individual is living in. I think is invaluable. On the flip side, as I said when we started off, I didn't know what I was doing as a social worker, and so we got to learn from them great tools, motivational interviewing techniques, self-determination, topics that we didn't know even consider. Patrick and I would walk into somebody's house and go, well, you just need to make a doctor's appointment, go see the doctor and take your medicines and everything gets better. Well, it's not as simple a dry cut as that, right? You know, you go take somebody's rug off their floor, that becomes almost a fighting match sometime, right? But educating and advocating and doing it in a way that empowers them to make the decision is the way to approach it, as opposed to just going in and doing these things. So you have a lot of resources in the community, and a lot of partnerships have to be built to make it work. So, but it's a great program, great idea for everybody. So any other questions, feel free to ask in the chat or the question screen, and I'll be more than happy to ask.
Seth, do you know where some of the other programs, you said there were 10, where they're located in the state? Because we have people from all across the state online.
Yep. So we have Boyd County EMS has one. You have the medical center out of Bowling Green, Kentucky has one. Louisville Metro EMS is doing one. Oldham County EMS, which is associated with Baptist Hospital, is doing one. Boyle County EMS is doing one. Laurel County EMS is doing one. Callaway County out in the western part of the state is doing one. Montgomery County is doing one, although when they started there, actually have to give them props. They're the ones that kind of forced the conversation, the EMS in Kentucky. They were wanting to look at strictly cardiac CHF patients, but I think that they're looking at evolution as well, and that's 8. And I'm sorry, I don't have my list in front of me.
No, I appreciate that. Just
well, after the presentation, I have the list at my desk. I'm not at my desk. I have the list. And what I'll do is when I get off, I will turn off my computer and mute myself. I'll go back to the chat and type in the 10 locations in the chat screen.
Okay, thank you.
Okay.
If a organization was interested in implementing this program, and if they weren't one of the 10 counties, is there a contact that they could get information so that they might implement something like this in their community?
Yeah, I'll put my email address. If anybody's wanting to start something similar like this, I'll put my email and my work number in the chat box when I do that listing. And yes, I would advocate. I think and I don't like the word silo. I think and I think it's such a cliche term, and if anybody's used it, I don't mean to offend. 5 or 6 years ago, that was the catchphrase. And I think the reality is that people are doing such good work in so many different avenues and so many different venues. And we aren't all together, always knowing what everybody's doing. And I think this type of program really can bring those communications and those partnerships together. When we started the program, we got a good fortune of going to Colorado Springs, Colorado in 2017. They had been operating for about 5 years, and there truly was a collaboration. It was Colorado Springs Fire Department. It was the 2 hospital systems. It was the Healthy Colorado Foundation. It was one of the insurance providers, one of the Medicaid insurance providers, and they were all literally working in the same building together. In-kind donations of manpower, of personnel, of equipment, of bringing all the resources together. And they were sitting down once a week, highlighting individuals and going, hey, I've got Seth Lockard. Seth Lockard's gone to the ER 6 times. Here are the barriers and issues that we need. Or Seth's fallen 6 times. He doesn't have home health. How do we get him engaged with the primary care so we can get him some home health? And sitting those groups in a room together, being able to navigate that. We're starting to see that conversation happen in areas in Kentucky. Perry County is doing something like that. Louisville, Jeffersontown is doing something like that. And so we're now looking at bringing that type of program into Lexington to try to see if we can help bring the partnerships together, because I think that's the key to getting individuals successful. I didn't know what I didn't know when we started this 6 years ago. I didn't know the amount of resources in the community. And I thought I was well connected to Lexington. I've lived here at the time for about 7 years. I've been on the fire department at the time for 11 years. And when I started realizing I didn't know what I didn't know and the amount of resources that were truly in the community, I think it's, you all would probably be in the same boat. In the same boat as to there's probably a lot of resources that you may not even be aware of in your community that help fill in a gap or may help fill in a gap. So it's really important to start looking around. So thank you.